So, good afternoon, everyone, and welcome to this meeting of the Social Affairs Policy Review Committee. I'm Anne Call MHK. I chair the committee, and with me are Mr. Tim Glover MHK and Mrs. Dawn Kinnish MLC. Today we're meeting with representatives from Manx Care, so welcome to this oral evidence session. And for the benefit of Hansard and anyone listening, could you please just introduce yourselves, including your title and how long you've been in post?
Okay, good afternoon everybody. I'm Teresa. I'm the Chief Executive of Manx Care, and I have been in post with Manx Care from the outset. I joined the organisation on the 1st December 2020, so almost 4 years ago. I know.
I'm Oliver Radford. I'm the Director of Health Services for Manx Care, so I've been in the post since the day that Manx Care launched, 1st of April 2021, but I've worked on the island within health since April 2016.
Good afternoon, hi, I'm Professor Tim O'Neill. I've been in post since the 15th of April this year, and I'm Executive Director of Social Care, Mental Health and Safeguarding.
Thank you. So I'll start with just the general things we usually start with, and that's, what do you believe are the best outcomes or achievement Manx Care in the past year?
Yeah, so if I start by giving a little bit of overview, but then I'll come to probably Tim first and Oliver to give specifics around health and social care. But I think in the last 12 months, we have continued to really stabilise the organisation in terms of quality improvement, responding to many of the CQC and Ofsted objectives and recommendations, and closed a lot of the recruitment gaps that we had. So I think where we've been particularly successful is we have now managed to recruit a high number of high calibre consultants to the island, and that has stabilised the organisation in terms of the reducing our reliance on agency and locum staff. I think within that 12-month period as well, if we think about the broader transformation, there's been a number of new schemes, and I'm sure Oliver will talk in those a bit more detail, but things like having an intermediate care service established, which started just before last winter, see and treat, clinical navigation, the multi-agency safeguarding hub, some of those real sort of partnership developments, I think, have really been strong across the last 12 months. What I would also point to is some real excellence that's emerging from our relationships with the Northwest and things like peer review. So things like the critical care network, the major trauma network, where we are receiving peer reviews and achieving very good outcomes. The hip fracture database, more visiting consultants to the island and being able to deliver services here rather than having patients having to go across to the UK. I think we've managed to provide really strong performance on complaints management and complaints resolution, and the MCAL services continue to be very responsive in that way. We've also delivered the Restoration Recovery 2 programme in the last 12 months, which has really improved the waiting list position on a number of areas. So, I think, before I hand over to my colleagues, we're now 3.5 years into Manx Care. Year one was very much, we were still in the midst of COVID, responding to the pandemic. We were also preparing for comprehensive inspection of Manx Care by both CQC and Ofsted. Year two, we were still coming out of the pandemic and stabilising our services and responding to some real quality, safety and compliance issues, things like information governance, safe staffing levels, but also having that comprehensive inspection, of which I think we have 90 reports across all of our services. And year three has been really trying to build on that stabilisation and start to develop sustainable services for the future and starting to look very closely at productivity and efficiency in the context of obviously the financial climate and the difficulties we're having around the finance, but also to look at the sustainable service models of delivery, which we have to sort of stand 5-10 years into the future and look at what that looks like. So our work is starting to now focus on what those services look like. Frailty, what does that look like given we're going to have a third of the population who are over 65? Safeguarding, where are we going with the broader agenda? So, I think, in summary, year one was a year of discovery. Year two was going through very comprehensive inspection. Year three was stabilising and then starting to look to the future. Okay. Yeah. Tim, do you want to?
Thank you. Yeah, thank you for the question. So if I just start with kind of the job card when I arrived into post is probably a good starting point. Following on from what Teresa said, we've achieved some really good stability in adult social care services, particularly in our safeguarding and social work services, which were unstable, I guess is the way to describe it. And staff were feeling as if they weren't contained and not supported well. So I put a lot of work into that over the last few months. And the culture and ways of working are developing well, and we can evidence that, I think. And that will continue. So that's not a piece of work that stops. We'll continue that work, and we're conscious that staff have been through a tough time. I think I'm the third director in this post in 3 years. So creating stability in that space. I've moved to the island, bought a house here, just moved in, which I'm very excited about, and that's all played well, I think, with staff. That I'm here to stay, hopefully, and create that stability longer term. Opening of Summerhill View when I arrived into post, moving out of Riatna Bay and successfully enabling residents to move into their new home in Summerhill View. We are at the very late stages of that. I'm touching wood at this point. Complex piece of work, complex programme of work, but at the moment we're on track with that, and that's been a superb piece of work right across the island, and the partnership beyond Manx Care supporting each other to get to that point. It's not been easy, but we're getting there. And then that will help us to understand our lessons learned around that in terms of what that tells us about the market moving forward and where we might want to go next, obviously in conjunction with government colleagues. From a safeguarding point of view, we're doing a lot of work to integrate. We've got 4 different safeguarding teams within my service. I'm doing some work to integrate them and to get them to work better together across children and adults' health and mental health. And that's progressing well. We've had some board activity this week that's focused on safeguarding, and that's been really positive, I think, in engaging our board and our non-executives in particular in that wider safeguarding work, with some really key messages around safeguarding being everybody's business and a wide responsibility across the island. Some really positive work on self-neglect, following a number of really difficult reports over the last few years around self-neglect. I've been speaking to our Chair of Safeguarding Board this morning, actually, and the report that's going to come through in the next few weeks will be very positive, I think, in terms of the progress we've made. But again, without repeating myself, that's not the end of the story. We need to continue to work hard in that space, and I think we started from a fairly low base in that area. But some really good work and some good wider engagement beyond adult social work, adult social care in that space. We've held the ring really effectively on the homelessness agenda and working well through the wellbeing hubs. Oliver and I are working together in that space through the wellbeing hubs to ensure that residents are effectively supported, working closely with government colleagues and the department. We've reviewed packages of care, and we'll continue to review packages of care, both to ensure that we use public money wisely, but also to ensure that residents are on the right packages for them. My assessment coming into post was that's something that was definitely needed, and we'll continue that work certainly for the rest of the financial year and beyond. As you'll probably know, some really positive work around CAMS and the beginnings of rollout of that really sound investment in children and adult mental health services, adolescent mental health services. And we've started the work on bringing that waiting list down, which currently sits around 800, and that will take us 12 months to get there, but we've recruited 6 really, really good clinicians to help us deliver on that. And then, of course, the wider piece of work around Thrive and the development of early intervention services for children and adolescents, which we're very, very strongly focused on, and the team's doing a great piece of work to roll that out. We've successfully commissioned a provider to help us deliver on that. Wellbeing in schools, we've rolled out, I think it's 4 or 5 members of staff now into posts in schools to help us with the early intervention agenda in schools. And then probably a bit more prosaically, retention and sickness are also areas where we've made a bit of progress, which I'm very, very kind of keen and happy to report back on. Retention and recruitment, as you'll know, is a significant issue for us. But just to highlight, particularly in our mental health services, we're doing much better in that space, and in children's social care. Converting agency to permanent is something we're starting to do increasingly well. And sickness rates, particularly in mental health, are starting to come down and consistently come down. And then just finally, before Oliver comes in, 2 or 3 other key areas. Proud of the fact that our CQC action plan, most of which was delivered before I arrived, I hasten to add. Most of the actions, not all of them, but most of the actions have been achieved on the CQC action plan in my area, which I'm really delighted about, and that's a lot of hard work to get us to that point. And the Ofsted plan, we're just talking to the department about the next steps in terms of oversight of what remains to be done in that area, and I'm extremely keen for us to work with the department and do that. There are some bigger system issues for us to address, which we may talk later on in the meeting about. And then finally, some really good progress in children's on the multi-agency safeguarding hub, which you'll probably be aware of already. And one of our risks and challenges in that area is long-term funding of the staffing for that, which we may talk about. The rollout of our Edge of Care programme and some Edge of Care support for children and people who are at risk of entering care. And some really good progress on our recruitment of foster carers, and we're on track to achieve our target for this year in that space. But I'll leave it there, thank you.
So thanks, Tim. So just to clarify, my responsibilities cover the hospital, so both Ramsey, Cottage, Nobles, primary and community care, as well as all of our partnerships, our links with our UK trusts that provide us with specialist services, mostly around Liverpool. So just in terms of, it's difficult to kind of download 12 months of work into a few minutes, but I just wanted to kind of expand on a few things that Teresa mentioned in her introduction. So we've had some really good success in stabilising the workforce across both the hospital acute sector and also primary care. So as Teresa mentioned, we've managed to recruit into almost every consultant vacancy within the hospital now. We were very reliant on agency staff and bank staff up until quite recently. In fact, when I took over medicine, the medicine division back in 2019, we actually only had 1 substantive consultant in post, and now we've got 18 consultants in post, which includes 5 geriatricians. So that's really positive, both from a service continuity point of view, patient continuity point of view, and the financial kind of management. That's been also repeated across all of the other professional groups. Nursing is a lot more healthy. We've had around 50 student nurses that have trained on Ireland come into work in Manx Care since we've been established. That's been supplemented by recruitment from both the UK and also beyond the UK, a number of international recruits that we've attracted. We've also managed to launch a number of grow your own schemes. So we in the last month welcomed our first locally trained midwife, apparently 100 years after it was first proposed, as well as launching our own paramedic training programme, which is in conjunction with the University of Cumbria, and we've currently got 3 people on that course, hopefully graduating next year as paramedics. So just having those permanent staff in place does, from a continuity of service, just from a resilience point of view, we've got those people employed rather than agency staff who may give us a week's notice and then leave. From a service development point of view, we've been working side by side with the transformation programme since Manx Care was launched, and from 2019 when it was initially established. Particularly over the last 12 months, we've seen a huge investment from the transformation programme around urgent care. So that is expanding our urgent care offer from just meds and ED, which it has traditionally been, to a much more kind of blended offer. So the presence of healthcare practitioners within the control room, taking calls, clinically triaging those calls, downgrading, upgrading as necessary, signposting to alternative services. So, whereas, previously almost 100% of people that rang 999 got an ambulance. Now we're around 70% of patients who ring 999 will get an ambulance. In the UK, that is a lot lower. That is around 40%. So, obviously there is a way to go with that in terms of the repertoire of alternative services that we can signpost, but it's certainly a good start. Supplementing to the control room and paramedics, we also have got 5 paramedics currently in training to become advanced paramedics, so being able to undertake more complex procedures in the home environment, prescribe drugs, etc. So rather than patients being brought in to hospital to receive that treatment, it can be done at home. And that's working in conjunction with the new intermediate care service that Teresa mentioned, which is essentially a service that sits between community and the hospital to provide some care for people at home. So if somebody is so for example had a fall, they may have been picked up by the ambulance service, they've been assessed, they don't need to come into hospital, but what they need is a bit more care at home. That's something that the intermediate care service can provide. Previous to that, they would almost always come into hospital and mostly require admitting into an inpatient bed, but now we can provide that very rapid response care service. But also intermediate care is providing that step down from the hospital. So whereas somebody may have completed their treatment in the hospital and maybe needing a bit of care at home, traditionally that would have gone through the social workers to be allocated a care package. That would have needed a financial assessment, but with intermediate care we can provide that much more, that care immediately on the day. So meaning that those patients can be discharged home earlier. That's having a real impact on the ground at the moment. I was doing some comparison of our OPAL score, which is the hospital's way of measuring pressure. This time last year we were in OPAL 3 almost all of the time, which is the kind of not quite the top, that's 4, but one down from the most pressured scenario. Now we're running between OPAL 1 and 2 during what is traditionally quite a busy time of the year. And certainly, speaking to colleagues in the UK who are really struggling with capacity within the hospitals and, declaring critical incidents and things, we are in a much better position. And, as Teresa mentioned, the intermediate care service was launched just under a year ago. But, we've spent the last year recruiting into that service, both from a carer's point of view, but also advanced clinical practitioners. So those advanced nurses, physiotherapists who can do that assessment and deliver that treatment at home. So that's been a huge kind of development for us over the past 12 months. Teresa mentioned frailty. We've as an island, a population that is ageing, and I did some research for a board presentation. We're actually the 3rd oldest country in the world. So we are between 25 0.8% of our population is over 65. We're just between Italy and Finland in the league tables. But as we know that our population is ageing, and that is due to increase up to 28% by in 10 years' time. So, a focus on, helping people, progress into older age, but remain as independent as possible is a real priority for us. As I mentioned, we've recruited 5 geriatricians over the past 3 or 4 years, which is actually an increase from 0 to 5. Amazingly, for a population who is ageing, we didn't have any geriatricians up until 4 years ago, which is amazing. But we've now got 5 working between the hospital and community. So the hospital is very much the reactive side. If an older person is admitted, they are provided with specialist care in the hospital that is focused on the entire person rather than individual bits of the body, like the heart or the lungs. So geriatrician's role is very much providing, generalised care. But we also more recently have introduced community services, so community frailty services. And over the past year or so, we've been piloting an initiative in the north of the island that actually sees patients at an MDT clinic, which is a geriatrician, a physiotherapist and a pharmacist will see a patient together in a clinic to look at their mobility, their medical problems and their drugs. And that's having a huge impact in terms of both reducing the amount of drugs people are prescribed, doing an assessment, a comprehensive geriatric assessment it's known as, and as well as looking at their mobility and actually working with patients at home or individuals at home to become more mobile and independent. I guess Teresa also mentioned we completed the Restoration Recovery programme in April of this year, and that's between 3 specialties, ophthalmology, general surgery and orthopaedics. We undertook over 4,000 procedures. That was largely undertaken by our own teams, but was supplemented by a third party, a commission provider called Synaptic, who provided some of the staff that we were, particularly in theatre and on the ward, so that we could get that high volume of turnover. And I guess just underpinning all of this is the improvement that we've seen around our data and performance management. So, it's all very well investing in the health service and improving capacity, increasing capacity, recruiting additional staff. But, when Manx Care was established, our visibility of data and performance was very, very low. And so we have invested in a relatively small team. There's only 4 people in that team to actually look at developing our performance management and our performance metrics. So whereas managers like myself running services when I first arrived on the island had very little visibility on performance. How long does it take for somebody between being referred to the hospital and being seen in the hospital, or being referred, for treatment and actually get into theatre. We didn't have that information, but now we have a huge array of data that is available for managers, services, consultants, etc., to be able to better manage their services. And so we are now, in a position where, as executives, we can hold our teams to account and look at trends, variances in performance, where areas where the waiting list might be increasing, looking at why, drilling down into that. Is that an increase in referrals? Is it a reduction in activity? It's a much more kind of tightly controlled environment now than what it was maybe 5 or 6 years ago, you know, and that, you know, just helps improve access to services. And then finally, I just wanted to mention our improvement in our relationship with our Northwest partners. So we spend around £25 million a year within the Northwest, particularly Merseyside, on the provision of specialised services, and that is a large chunk of that is around 50% is for non-elective, so that's emergency cases. So whether that's a major trauma patient, somebody who's got a bleed on the brain, somebody who is say a neonate or a child who needs specialist treatment, and around half of it, well no, not quite half, around a quarter of it is for planned care, so people being referred across for procedures that we can't do. So that might be a particular orthopaedic procedure that we can't do. That might be patients who require cancer surgery. And around 25% of it is drugs, so cancer drugs in particular, but also, you know, the newer generation of drugs for like cystic fibrosis and things like that. Up until, you know, a couple of years ago, our relationship with those trusts was very transactional. It was, you know, a consultant will refer a patient across, we'll get a letter back to say, I've seen your patient, this is what we've done, and then we'll get a bill to say, you know, this is the cost of the treatment. And that was really it. But, you know, we've got 11 trusts that we deal with a lot within Liverpool. And the two biggest trusts that we deal with is Liverpool Heart and Chest and Liverpool University Hospitals, but there are others such as Liverpool Women's, Alder Hey, etc. We've now got between 5 of those trusts a regular quarterly meeting where we discuss service developments collaboratively. So one of the recent successes is negotiating access to the same heart attack pathway as people in the UK get. So previous to that, people who had a heart attack here on the island would be brought into Nobles. They would be given a clot busting drug, and then they would be admitted to the coronary care unit, and then they would be transferred across to Liverpool for further treatment, and that journey would take about a week. Now we've got a pathway whereby if somebody has a specific kind of heart attack, the most serious, that's diagnosed in the ambulance. The patient is transferred straight to the airport, transferred across, and then go into the cath lab, the catheter lab, whereby a stent is put into the heart, and that time frame is now 2 hours. And the actual impact of that in terms of cardiac rehab is huge. And it also means that we have the same level of treatment as anyone else in the UK, considering, you know, despite us being on an island. And in fact, you know, our response time, so what's called call to balloon time, is actually better from here than it is from quite a few areas, more outlying areas within Merseyside. And we've got other developments in train such as like the more modern way of managing a stroke, which is to take the clot out directly rather than give a clot busting drug, and also some visiting services. So Teresa mentioned bringing more visiting clinicians over. So rather than sending, say, 20 patients across to the UK to be seen in a clinic, we bring the consultant here and they see 20 patients here, and that has that has launched, and you've probably seen the media stories. We've got 3 consultant orthopaedic surgeons coming across over the last couple of months, doing quite specialist clinics, and we're also doing something similar with Liverpool Women's, where they send their gynae oncology surgeon across to do cancer surgery here on a monthly basis. And we're also looking at contracting, so bringing our the urogynae surgery, urological gynecology is its proper title, service across. So yeah, a lot of developments over the last 12 months to be proud of, I think.
Yeah.
Mrs. Kinnish.
Could I just expand a little bit on something that you mentioned, Oliver, just then? Thank you for your contributions, each of you. You mentioned about the changes in urgent care, where it's not just about medicine and ED, and talked about the triage service that now takes place. And that's great to see that there's been a reduction in the demand on ambulance service to 70%. You mentioned the figure of 40% in the UK. Is that a benchmark to be aiming for? Because is that delivering the right level of service in the UK? Not necessarily seeing that come back in what I read. And I just wonder where that benchmark would be set as to what would be a good indicator for us here on the Isle of Man.
I think it depends on... I think we should probably not focus on the number and focus more on the range of services that we can signpost to. So if somebody rings the ambulance service at the moment and their call is categorised as the lowest category, category 5, it's known as, so that they will be put through to the clinical navigator, and they'll have a discussion around, why have they called, and what are the options that is open to that person other than receiving an ambulance at home. At the moment, our options are a lot more limited than the UK. So generally it could be to go and see your GP the next day. It could be go and speak to your pharmacist. It could be could you make your own way to A&E or go to meds. I think one of the pieces of work that we are doing is really looking at what those other pathways might be, so I think what we need to do is probably concentrate on actually is there more that we can do around developing those pathways before we then set the limit or set the target as less. I think at the moment around 70% is probably the best that we can get it. We know that so we don't have a clinical navigator in the control room 24 hours a day. It's around 12-hour cover. But that probably is a reasonable investment because the number of 999 calls drops off significantly during the night. So, actually it's balancing out the benefit of the investment versus not. So.
And we've, just to sort of add to that, we've always focused on what we're doing under the umbrella of right care in the right place at the right time, delivered by the right person. And that means we won't always be able to, or neither should we, replicate what's delivered in the UK, because a diversionary pathway into the community, well, actually you can't set up a new service just on potentially what could be very small numbers, and that's where we've got to sort of take it incrementally and work out what are the right pathways to have away from acute care, and what can we sustainably deliver, and what is financially viable for us to set up. So it is an incremental and very considered approach, and I think this is where we have so much opportunity to look at what works here for the island, without sort of slavishly trying to follow what the UK does, because we cannot replicate. We just cannot replicate what happens in the UK in terms of the scalability.
Thank you.
So, what's been the biggest challenge in the last year?
The money. The money has been the biggest challenge. Partly because of what we've needed to do internally to really deliver against our strategic objectives. So, I think in the examples we've all given, we have definitely brought practice up to date, delivered some best practice standards, and which ultimately impact on the outcomes for the people we serve. Overlaid with the need to really transform and bring in the right workforce to deliver the right quality care. And if we think about the context of the last couple of years, so we're sort of coming out of COVID, we've been through comprehensive inspection where it's really important the organisation is seen to respond appropriately to all of the published reports, which set a very new high standard for health and care on the island, and in a context of high inflation. So, and that then drives inflation of drugs and consumables, but also some high pay awards. And of course, we're an organisation with over 3,000 staff. So if you think about the totality of the last 3.5 years for Manx Care, we have had a significant uplift in funding. There's no doubt about that. We've had £78 million worth of additional funding since our baseline year, with a significant uplift in this financial year. However, of that £78 million, £30 million over the last 3 years has gone on pay, the pay uplifts for the workforce we have. Because we've had 2 years of 6% pay uplift, a year of 4%, and we're at 4% on the table for this year. £33 million has gone in inflation of drugs and consumables and the tariff price we pay for those patients who we transfer off island. And then we have needed to make investment across the organisation in a number of new services which we have been mandated to deliver: the vaccine service, the long COVID service, but also to respond to some of the safety and compliance issues that we identified. So information governance, health and safety, risk management, safeguarding. Our safeguarding team is now a team of 12. There was one practitioner. And safe staffing for our wards. The acuity and dependency of our patients has to be continually assessed, and as a result you have to then respond to the staffing levels and the tools that you use to be able to safely staff your areas. And so £13 million has gone on safe staffing and compliance. So when you think about the totality of the 78 million, it's really allowed us to stand still. So 30 million on pay, 33 million on inflation, and 13 million on safe staffing and core compliance and those new services that we were asked to deliver through our mandate. So yeah, and I think the money brings a level of scrutiny on us, which is right. But I think when Sir Jonathan Michaels wrote his report and when Manx Care started, I don't think there was ever the intention or the expectation that this was just a 3-year piece of work and this wouldn't take an awful lot longer to really deliver all of the recommendations and get to that point of having sustainable, high-quality healthcare for the island. We know the financial context has changed during that time, and we completely understand that as Manx Care and the provider. But I think this is the difficulty we are now in when we have really high expectations coming out of COVID. A very ambitious mandate of what we are expected to provide, and the financial climate has changed. So we are being asked to do a lot more with a lot less, while still really trying to drive out the efficiency savings and change those clinical models so ultimately they are more sustainable and more cost effective in the long term. And I think that's been a big ask on us.
Mr. Glover.
We're going to stick with the budget.
Of course.
In June, you told the Public Accounts Committee the fundamental question we do not know is what we are currently delivering and what it should cost. How and when will we get to the position where you know what it should cost so that the budgetary pressures Manx Care faces can be more clearly understood?
Yeah, and I think that
was in June. So, I mean, is that still the case, would you say?
It is still the case. I mean, there obviously has been some recent developments whereby there's a slight change of approach in that we are being asked to develop the operating plan before the mandate, rather than the other way around. That does give us the opportunity to look at what our indicative budget for next year is able to deliver, and what decisions ultimately will need to be made around service delivery in response to that. And I talk about this quite a bit, so apologies if I'm repeating myself. In an ideal world, you would have a very clear specification for the service that Manx Care is being asked to deliver. And if we had a clear specification, Manx Care could then cost it and understand the workforce requirements of delivering that, and the KPIs which sit with delivering against that particular specification. And if we did that for every service we had, with built-in efficiency through the KPIs, we would have a collective understanding of this is the service we want, this is the workforce we need to deliver it, this is what it's going to cost, and therefore you have that confidence that sits within a quantum of funding that you have available. And then you can overlay assumptions around pay inflation, around other inflation, around new services we may be mandated to provide. But Mr. Glover, we don't have that level of transparency across the system, partly because given where we are in the separation, we're just not mature enough either as Manx Care or DHSC. But as Oliver has also alluded to, the data and information which sits underneath all of that is still not as mature as it could be in order to inform that. We are so much further on than where we were 3 years ago, and I think this year the change of approach, we will have a really good go at describing what the indicative budget buys in terms of service delivery for the island.
Can I just ask then, it's clearly important at the same time that we have a safe and an effective and an efficient health and care service. So accepting that at the moment you don't know exactly how much this should cost, do you have a headline figure which you think would be enough to deliver what is specified in the mandate as of now?
So I can only go yes, is a simple answer to that. We obviously submitted our financial plan to the Department of Health and Social Care in August, which had all sorts of assumptions built into that. That was very prudent around, essentially delivering the mandate as is, so nothing particularly new. The mandate that we already have in place for 24-25, with some assumptions around inflation, etc. And we believed we needed 377 as a minimum, and if then we wanted to build in a greater level of financial contingency, or if we had new information. For example, the expectations around pay, if we think about the context of the medical staffing and their expectations around 12.6%, and that being not what we had financially planned for, we're sort of closer to 396.
The money that was ring-fenced at the previous budget, the 2% income tax increase, is that additional to the 346 million budget, or is it part of that, and is it being used for a specific purpose, and have you in fact received it? So
for this financial year, our operating budget for this year is 347. That 347 assumes that we were always going to deliver £4.8 million worth of savings. So that has come off that position. Of that funding, and I think this comes back to the presentation we provided into the Timwell briefing on the 5th of February. We knew that operating with a budget of 347, despite that being a substantial uplift, 43 million, we knew that posed some challenges given where we landed the outturn position and requiring the £30 million supplementary vote. So that 347 required us to make a £19 million cost improvement programme. Because of that outturn position of 338, that really only left the organisation with £9 million to play with. The pay award based on 4% would cost the organisation £8.2 million. Inflation was going to cost £7 million. And we also had business cases which would hit our recurrent position of £2.3 million. So you can see that of the £9 million we got, which was new from the baseline position we ended in, we were already at 17 before we could address any cost pressures. So essentially, the £9 million, which was sort of new, only really allowed us to do the pay award. It didn't address inflation, didn't address the other things I've discussed.
Just very briefly, before we move on to other areas, is it fair to say that inflation within a health setting is different to the headline figure that we see of what a current inflation is? Because it appears to me the price of drugs and other things are subject to a far higher inflationary influence.
It is. I think we've seen 22% uplift on drug inflation. So
it's way out of line.
Way out of line. And if you... and the tariff price increase, so the price the Northwest charges had an 8% tariff uplift. So 8% on £25 million worth of spend is significant again.
And just on budgetary pressures, clearly there are current pay disputes as well, with the doctors balloting and nurses today, I think I read,
Yes, that's right.
looking at things as well. So that's added pressure, isn't it?
It is.
And in fact, I think I've got a headline saying that you nowhere near can afford what the BMA is claiming.
No. So our budgets for this year assumed 4%. But obviously, we have not settled with any staff side. So PSC hasn't settled, MPTC, NJC has not settled, and neither has medical and dental. And if we just took medical and dental as the example, to go from what we're currently budgeted for, and made assumptions of the 4%, to pay 12% would cost the organisation another £4 million.
In the shorter term, can you tell us then what you're doing to bring spending back in line with the budgetary provision? And within that context, you obviously put a range of things forward which have now been rejected by the Council of Ministers. So where do you go?
Yeah, so our cost improvement programme, which is the wide-ranging schemes of the schemes that we established at the start of the year, that is expected to deliver £12 million worth of savings. In response to the overspend position that was reported mid-year, in the summer, we identified a further £5 million, which would obviously close that gap, but didn't close that gap completely. And obviously what you're aware of is that Manx Care was instructed to prepare additional schemes which the board all had agreed and considered were unpalatable. So these had a direct impact on frontline provision. And obviously those are the ones that were submitted to COMIN. So what we're working with at the moment is the £12 million, which we're working really hard to deliver against, and that's reflected in our current forecast. The additional schemes of £5 million, which are really looking at efficiency, reducing bank, reducing agency, looking at other contracts that we can stop sooner. But essentially there is still a gap. And there is still a gap, which, as a board, we're recognising is between 7 and 10 million. There remains other risks which sit outside of that. So, for example, as Oliver's described, tertiary is incredibly volatile because at least 50% of what we do through tertiary is unplanned work. So if we have someone who needs a a transplant or a long stay on intensive care in the UK or a particular bad run of major trauma, there's no way we can impact on that, and we will have to just respond to the costs of that. And tertiary can swing a couple of million in a month. You know, a high cost mental health placement could cost £300,000 to £400,000 a year. The volatility is quite high, and therefore the risks are quite high, which is why as an organisation we place a lot of importance on trying to control the bits we can, looking really hard at efficiency, productivity, and trying to reduce the spend. But as we sit here today, Manx Care will still end the year in an overspend position.
How challenging then is it to have a focus on cost saving when you're delivering a health and care service where the front line will always want to be providing the best care to patients?
Yeah, I don't know whether someone else
I'm
wants
very,
to.
very happy to start the answer on
Yeah.
that. Thank you for the question, Mr. Glover. You'd expect me to say this, and it's absolutely the case. It's really tricky to keep staff motivation high in this environment. I would say that generally speaking, my experience in the first 7 months in post is that we're managing to achieve that, but it's increasingly difficult to do that. I think one of the things I've experienced coming into post is the pressure of 1 year settlements and late settlements are a problem for us without question. You know, planning transformation and planning big recruitment drives, different ways of working in a very narrow time frame is very tricky. But staff morale is holding up well, and it's an enormous credit to the staff group. Certainly I'm responsible for, and I'm sure Oliver would say the same, that morale and commitment to the overall programme of work is absolutely still there for everyone to see. And I'm sure you've been to various services and do walk-arounds, and that's absolutely there, and we're very fortunate on the island to have that. But the pressure is increasing from that point of view.
I guess the follow-up there is how much time now is being spent trying to balance the books.
Just one quick comment on that. One of our non-executives certainly it comes to mind in some of the things we talk about at board. There is a lot of time spent looking at the financial position, and I think all board members are aware. Yeah, we want to make sure we balance that out with focusing on transformation and providing the absolute best care to every resident, and that balance isn't quite there at the moment. That would certainly be my judgment.
And then in the longer term, do you believe that the transformation programme and the steps being taken to move to a system of integrated care, will that ultimately lead to a lower cost health service? Or is that a pipe dream?
I think what it could lead to is, I guess, a universal recognition that you are delivering cost-effective care. So over time, demand goes up. So you might not spend less, but I think one of the risks we have at the moment, and it's one of the things we have to grapple with, is if we just try and do the 1 year type of solutions and don't invest in the longer term, ultimately that demand will be there and it will cost us more in the long term. So I see our job as Manx Care is to develop those new ways of working, different clinical delivery models or care delivery models, which are able to demonstrate this is a really cost-effective, good outcome way of delivering care, which is sustainable. What I would say, and we've touched upon it in some of the achievements where we have made those changes, is a lot of our models of care are still quite traditional. And because we've had 3 years attempting to really stabilise the organisation, getting into those very quite difficult discussions at time about what the models, why they would look different, why you might have different professionals providing that care. Those are things that we still need to do. So I think, in answer to your question, one of the things that you would ideally want to get to as a system is a sort of satisfaction and a recognition we are delivering really cost-effective care which benchmarks favourably against other similar jurisdictions to say we are getting really good value for money from the services that are being provided by Manx Care. They are efficient, they have good outcomes, they are sustainable. But I think that broader question about the quantum of money is much more harder to answer, and I think fundamentally there'll be some difficult choices about what we can have here and what's affordable within the envelope, and how long it's going to take us to get to that sort of question of value for money. Because the one thing I do say is we have been able to deliver £10 million worth of cost out savings every year, pretty much. And I can still see 2 or 3 years where that's feasible through driving efficiency, doing things differently, which won't impact adversely frontline delivery. But it takes time. The process of taking people through change is not quick. And if we talk about sort of where we were at the start of the year, our ambitious CIP plan had all sorts of assumptions about how quickly we could do some of that change. And what we've learned over the last few months is it takes longer to do that, to take people, to consult properly with the public, and to take our clinicians and staff on a journey of what does that look like, to fully engage them in what's going to be different. And I have to sort of acknowledge, if we think about COVID, then comprehensive inspection, and then a lot of change around transformation, which has happened already, keeping our staff feeling involved, engaged, motivated to deliver the best quality care, that change process has to be really managed carefully and respectfully.
What do you make of you often hear comment from the public, don't you, that there's too many managers within Manx Care, not enough focus on the front line. You then, when you're asked to make cost savings, produce a list of pretty unpalatable options. And that may still be the case. And I just want to draw out, you've mentioned, obviously, we've got an ageing population. We're very high up on that. Shingles vaccines, where are we with that?
That's going to be rolled out.
It is?
It is, yeah.
Because we just heard a few instances of late where people haven't been able to get their shingles vaccine.
Yeah, so it obviously was on the list of something which hadn't already started, which could be not progressed if that was the decision of
Because that's a
Comey.
really important vaccine for the elderly, isn't it?
It is. And we have always been really clear about following JVCI guidance here on the island, and obviously that's recommended there. So yes, I mean, we obviously had it on the list, and we've obviously since had the decision to proceed. So 1st of December, is it, Oliver?
1st of December, but it's probably worth just noting that's going to bear cost pressure of around 600,000 a year, because the new shingles vaccine is extremely expensive. We rolled out the new RSV vaccine, which is a respiratory illness. That only cost 30,000 to roll out, so we rolled it out. But the new shingles vaccine is significantly more expensive, which is why we are so behind the UK. The UK rolled out shingles vaccine back in September 2023, but due to the pressure that Teresa mentioned last year on the finances and rolling it onto this year, we've just it's just been a pressure that we haven't been able to absorb. But given the decision earlier around what we should proceed with and what we shouldn't, we took that decision to proceed with that. But yeah, it's yet another cost added onto the pile with not really much coming, not the commensurate increase in budget. So
I started that question by talking about layers of management. I mean, is that the case?
No. I think we have benchmarked, and we know our management costs are around 2%. Oliver did the piece of work, and that benchmarks favourably against UK comparators. We have had to make investment in some of those key posts which are linked to our safety and compliance and effective delivery of frontline care. So the investment in business intelligence and performance management. Health and safety, there was no health and safety provision in the organisation, and we did try to access that, but that wasn't available to us. And health and care is an incredibly risky environment where health and safety is of critical importance. Risk management is critically important. You know, a lot of risk sits in health and care, and it's appropriate that the board is managing risk effectively. Information governance, you know, we had a torrid time with information governance for a couple of years in that we'd had performance notices from the Information Commissioner because we were just not compliant with any policy and procedures around information governance. So again, we have invested there. And I think that's part of the concern that it's part of the concern that I have, that we are so heavily criticised for potentially investing in posts which there would be no other NHS or care organisation anywhere in the world which would operate without those roles. They are of critical importance. If you don't know the risks and you don't have a good risk management system in health and care, you cannot function effectively. You cannot give any assurance either to your own board or externally about how you are managing some significant risks that sit within the health and care setting. But I do understand that when you've got an organisation that's overspending, it brings real scrutiny, and there's an acceptance of that. But I wouldn't want there to be any assessment that we are choosing to invest in these posts whilst stripping out frontline provision. Every single post that has been put into Manx Care has been through scrutiny, through a business case review group process. And what we have to first and foremost do as an organisation to protect the registered professionals who work within the organisation and the public is provide safe, compliant care. It's the fundamental basic of why a health and care system exists. We should attempt to do no harm.
Jen.
There's just a couple of things I wanted to pick up before we move on. Activity-based costing is one of the main planks of your operating plan. What progress has been made in this area, and how much of a priority is that for Manx Care?
So I'm leading on this along with the finance director. I came from a large NHS organisation 8 years ago, and activity-based costing had been a project that had been running for 5 years as I left, and it took around another 3 years to do. It is a essential piece of work that we need to carry out. Obviously, our finances are managed. The mechanics of the finances are managed through Treasury, and they're going through a process of completely changing their financial management system at the moment across the whole government. So, whilst we would like to progress on that, and we are starting to have some initial conversations around that, and through the transformation team looking at some subject matter expertise to help us with it. It's difficult to start actually delivering it until the Treasury have implemented their new system. We are making the groundwork, starting the groundwork on it. But it will probably be a several year process to actually deliver. But once we have it, it will be fantastic to enable us to very, very accurately predict, based on the data that's within the activity-based costing system, growth factors, activity, to actually say over the next 10 years, based on this growth, this is what the system is going to cost. But actually looking at actually tinkering with service delivery, actually the cost of it, if you do this tinker, the cost of it will be this. I attended modelling. I attended a conference earlier on this year where there is a system-wide activity-based costing that's based on AI down in Buckinghamshire, and they're able to tweak elements of their system, and actually the cost of it, the activity levels going to certain bits of the system is able to be modelled, planned out. So actually, investing in additional capacity within intermediate care has this impact on the hospital services, and it costs this. And as an island with a single system that we work in under Manx Care, that's something that we can deliver. But there's lots of other kind of external factors that will impinge on that, but it certainly is something that we want to dedicate some of our time to deliver, because it could really be a game changer in that prediction, in that modelling.
Just another, in one of your answers there, you mentioned indicative annual activity plans. That's hard to say, isn't it? As we're nearly 8 months through the financial year, how many have been developed so far?
So there's an indicative activity plan for every area.
So they're all done for each area now?
Yes, they're all done for each area. And we monitor those on a monthly basis through our... so each care group, so surgery, medicine, mental health, social care, has a monthly performance meeting. I chair it for my areas, Tim chairs it for his areas, and we go through the activity plans, and the plans versus the actual. So, where there's been there's an activity plan set for outpatients in gynecology, for example. Are we on track? Is it tracking higher? Is it tracking lower? Let's look at the reasons why. Is it referrals? Is it a consultant who's been away or off sick? And that maturity around our data that I mentioned earlier, that means that we can do that. As mentioned at the beginning, that's something that's very new. We didn't even know what our activity levels were, never mind having a plan for it. So.
If I may, Mrs. Scott, just to add to that, that work's critical. I think at the service level we're already remodelling where we can. We were talking yesterday, day before, about safeguarding. We've gone from 200 referrals to 1,200 referrals a year on average at the moment. We're managing to effectively deal with that with no additional investment, and the reason we can do that is because we remodelled the way we operate and the practice model that's delivered. It's not rocket science, if I may say that, but it's important work locally, so we're not kind of waiting for the activity model to arrive. I think the brilliant work that Oliver's leading on, notwithstanding, I think we're doing that at the service level and where we can very effectively, and we've done some work like that in the hospital as well.
And is that rise due to the fact that you're providing more of that service now? We haven't suddenly gone from one thing to the other, it's just that it's able to be referred now where it wasn't prior to that.
I think it's a bit of a mug's game saying exactly why that's happening, but in simplistic terms I would argue it's because the more we look, the more we find, which is good for residents and good for the island. But we were expecting that increased need, and it's arrived.
Thank you. Mrs. Kinnish, do you want to?
Thank you. Just before I move on to the operating plan, I've just got an additional question in relation to costs and management of costs, really. And a Timor question was raised around consultant salaries that you'll be aware of. And we did have shared with us, and it was shared publicly, about the pay scales for medical professionals. So if I just give by way of example, a 2024 consultant salary was listed as 168,275, which was also annotated as being over 31,000 more than the latest UK pay agreement for that. And I think when I was just scrutinising some of the top three salaries that had been paid to consultants, two in excess of $500,000, one just under $500,000, I just wondered what is on your boardroom agenda around the management of that, and whether the statements that have been made earlier about the fact that you've been able to recruit more consultants to posts, and whether that would make a positive impact on some of those salaries, or whether this is still going to be a significant risk area, and that some consultants are effectively earning what would be the equivalent to 3 members of staff for one post. And I know that's said in a very raw form, because I understand there's lots of complexities around the contract in terms of the programmed activities and on-call, etc. But I think if you're just looking at this from a raw observation as a member of the public, trying to understand how individuals are earning such significant salaries when actually the baseline salary is so different, I just wondered if you had any comment on that.
Yes, so I think this is of the utmost and the highest importance to the Manx Care Board. I would say that simply because it's so fundamentally important to service delivery, but also, our medical workforce costs the organisation £48 million per year. So it's a significant proportion of our £347 million worth of spend. That sort of overall sort of salary position is driven by the fact that we have small specialties where the job plans do not allow prospective cover to be built in. So if a person is away, they're able to attract bank payments for covering that other consultant. And indeed sometimes, and this is including 24/7 on-call cover. What we have acknowledged is there is a substantial legacy issue around the quality of job planning here on the island. That is well understood in the organisation, and our medical director, interim medical director, has been working to try and address this for at least 2 years. I would suggest there is still an awful lot of work to do, but job planning, and we have a job planning policy, we must have full engagement of that by our medical workforce. That must be done properly, and there are very clear processes around what that job planning looks like. That must be supported by diary exercises to be able to validate and assure that the intensity of out-of-hours work is appropriate. And then ultimately, we then have some service-based decisions to make. So, for example, if we only have 2 consultants in a service which is leading to such excessive costs because we are reliant on bank to deliver that service, well, actually there's some options there about bringing in additional consultants in order to provide a much more cost-effective service. And those are very active discussions at the moment. We have identified, and it is part of our cost improvement, there's a difference in the consultant contract here to across. And there is probably limited opportunity to change that at this moment in time. But what we must do as an organisation is focus on protecting and ensuring direct clinical care, PAs, are in place, and some of those non-supporting PAs are addressed. And we've got a programme of work underway at the moment, which is looking specifically at the SPAs, so the non-frontline PAs, but making sure full adherence to the job planning policy is in place. And only when you have full adherence are you able to effectively workforce plan your consultant workforce and make changes which ultimately deliver more value for money for the services. So bank rate is a premium rate. Mm-hmm. It costs us the most money. So we would want to try and transfer some of that bank spend into substantive appointments where possible, because that is better value for money for the organisation. But I guess to come back to your original point, a very high level of focus placed on this by the organisation at the moment.
Thank you. I just want to move then to the Transformation and Mandate Oversight Group. Has this been established now?
Yes, I chair that.
Okay, and what's the membership of that group and how often do they meet?
So we meet monthly, and the membership is essentially every of the 5 priority areas of the mandate has an executive lead who report on that every month. And we also invite the DHSC into that meeting. So there is sort of full transparency around the discussions we're having, the progress we're making, the reporting packs. So yes, it's supplemented by some of our sort of project managers, some of our operational teams, but the accountability is myself as the chief exec chairing that, with the executive leads for each of the priority areas reporting in and providing assurance on progress. And there's a very detailed reporting pack which sits alongside those papers, and that is reported into the board on a quarterly basis, and also into the mandate assurance meeting on a monthly and quarterly basis.
Thank you. So in addition to meeting the mandate requirements and transformation work, Manx Care has a number of improvement programmes, as we know, and following inspections and reviews, and is involved in a number of cross-government strategies. How realistic do you think it is to deliver on all of this?
I think we as an organisation, and that was why we tried to sort of combine transformation and mandate, because there's such synergies and similarities. So we've always been very committed to try and deliver as much as the mandate as possible. Despite us acknowledging there is a funding misalignment that we're all committed to addressing. As an organisation, we take our system-wide responsibilities really seriously. Both Tim and I sit on the safeguarding board. We sit in the community partnership space, criminal justice. We take it really seriously that we play a very strong role into those wider system programmes of work and improvement. We were having the conversation earlier this week that, I think there is an opportunity for them to be sort of slightly more streamlined, to be able to get, probably a more impactful and avoid some duplication across the system. But I think we work incredibly hard to play a very active and influential and important part of the system, and really try to deliver for the system what's been asked of Manx Care, whether that's on the mental health agenda within the schools, looking at right care, right person in terms of supporting the police's response, in terms of, I guess, CAMS and the criminal justice system. I think our staff members chair a number of the groups on the safeguarding board, and have inputted into that. The sort of strategic planning around TT, motorsports, Oliver sits on that. I genuinely think we go above and beyond to try and support those wider government and other departments' endeavours.
If we just want to move now to primary care at scale strategy, what's the overarching aim of the 22 primary care at scale strategy?
I guess the overall kind of objective is to make the primary care system as sustainable and accessible as possible. We all know that there are difficulties in being able to access timely GP appointments, and so really the focus is to improve that. Since the launch of the strategy, we've focused very much on stabilising the system. There's elements of the system that were quite fragile, particularly in the early days. We had a kind of demographic time bomb for the GPs where a large proportion of them could retire. So probably around 25% of the GPs could retire. We were finding that a lot of the GP practices had high levels of vacancy, and we even had, as you will know, we had one GP that handed back their contract back in early 2023 Ballasalla GP practice, which we took over ourselves. There are other elements of primary care, so dental services, optometry as well, but primarily our focus has been on stabilising the primary care, the GP system. The way that we've done that is essentially looking at increasing the capacity of GPs, and we've done that through a number of ways. The earliest project that we looked at and have implemented is to introduce first contact practitioners in GP practices. We initially focused on introducing first contact practitioners for physiotherapy, MSK, musculoskeletal problems. Around 25% of GP accesses around pain, joint pain, etc. And actually having advanced physios working in those practices who, can prescribe and can do more advanced techniques, assessments, etc. Actually means that there's a large chunk of demand that can go in a certain direction, and they are able to refer into the hospital. And we're even looking at actually those first contact practitioners being able to add patients onto waiting lists, so they don't even need to see an orthopaedic surgeon. They can be added, due to the quality of their assessments. They're actually looking at doing that. And more recently we've introduced that same principle of first contact practitioner within mental health. So people who access the GP due to low mood can actually be seen by a mental health practitioner who can provide more of the talking therapy rather than the medication. That's something that is relatively newly introduced. We're also looking at doing the same for pharmacy, so patients who access the GP for maybe repeat prescriptions, pharmacy advice, drug advice can be seen by a pharmacist. So it's actually placing rather than the GP who is a general practitioner is expected to be able to provide advice with a range of things, actually introducing those quite specialist individuals into those GP practices to be able to support the work of the GP, so the GPs can concentrate on the more complex disease management, referrals into hospital for suspect, whether it's people are worried about they might have a cancer or whatever, the GPs can concentrate more on that. We're also looking at introducing, we're actually piloting a virtual GP. So rather than having just the GPs on the island, we have an ability where there is an excess in demand to be able to activate a virtual GP service. So a patient might be able to speak to a GP on the phone who's not based on Ireland but has access to the full health record in front of them, so they'll be able to provide that support on the phone. We're actually looking to pilot that within the Ramsey Group practice, hopefully starting very soon. And what they're going to be concentrating on in the first instance is to look at what demand they can take off the GP that isn't patient facing. So, looking at results, looking at, letters from the hospital, deciding what to do, flagging things up, which actually takes GPs quite a lot of time, just, not seeing patients, looking at what we can do to take some of that workload off them through the virtual GP. We're also, I mentioned earlier about frailty. A lot of GP time is spent managing people who are older. Maybe they're starting to develop multiple problems, whether that's mobility problems, actual medical problems, breathing problems, heart problems, and asking GPs to manage lots of different problems in one 10-minute slot can be quite difficult, which is why we're looking at introducing piloting the frailty MDT clinic, which is, as I mentioned, is a GP, geriatrician, physio and a pharmacist in one clinic, so that they can and these clinic slots are about half an hour, so 3 times as long as a GP slot. Being able to manage those multiple problems together, and also looking at medication, because quite often multiple problems come with multiple drugs, and whilst those drugs treat the actual issue, they might interact with each other, and actually having a pharmacist there to say, actually, that if you have that and that together, actually lowers your blood pressure, and it means that when you stand up you might get dizzy and fall over. Let's change it to this.
So it sounds like some really positive things are happening in that space.
Yes.
Are there any particular big challenges that you're facing in delivering that strategy?
Well, I guess fundamentally we've struggled with project management support. With that, that has we've managed to sort out quite recently the funding of that project management, but we haven't been able to attract someone. So actually the role of advancing the primary care at scale is being handled by people that are already in the system. So our primary care general manager is also having to lead a lot of the work. Our primary care network lead is having to lead a lot of the work, and they already have kind of busy day jobs. So we are trying to go back out to advert to recruit that person, so there is someone dedicated there to be able to push it forward. I guess the overall primary care at scale strategy, when we first scoped it out, was quite expensive. And obviously with the financial discussions we were talking about earlier, to be able to deliver the full primary care at scale strategy might be cost prohibitive, but the small steps that we're taking, whether that's the first contact practitioners, whether that's frailty, whether that's virtual GP, are making kind of small incremental steps towards it. All of these things do cost money. We do have a transitional funding from the transformation team, so all the things we've spoken about, first contact practitioners, virtual GPs, and some of the urgent care work is funded on a transitional basis for normally around 2 years. That hits the Manx Care budget after 2 years, and given what we've spoken about, the other unavoidable cost pressures on our budget, we do need to be careful that we're not storing up a financial problem maybe a bit further along the line. Not sure if there's anything.
Well, you might want to correct me, but as I understood the primary care at scale was to put things to sort of front load the service effectively, so it wasn't putting financial pressures on the more expensive hospital care.
Yes.
Is that's
that's correct. But as Teresa mentioned earlier, that a lot of the transformation work is simply helping to basically address growth. So our system is the demand is growing across all the system, whether that's urgent care. So our ED demand is going up around 15% a year. And that's translating to emergency admissions. Our referrals are increasing, linked to ageing population. One of the stats that I pulled out as part of the frailty presentation, but this relates to the entire population, is that in 2016 there were 56,000 people on the island who had one or more long-term condition. That's increased in up to 70,000 in 8 years. So our population is getting sicker, and that is translating to overall demand on the system.
I think one of the challenges with transformation is that transformation effectively put in services that didn't exist. So it wasn't necessarily taking one particular service and changing it into something new with the same resource. It was having to put in something new. So the ambulatory treatment unit, the intermediate care service. These were all new developments. And I think one of the things that has recently come to light from talking to Mr. Ashford, who obviously was around at the time of the Sir Jonathan Michaels report and the separation of the DHSC and Manx Care, was that the expectation was that these services would be funded by transformation, and the budget into Manx Care would be sufficient to continue the transformation once the non-recurrent investment had finished. And of course that hasn't really happened, so that has slowed down transformation, because ultimately, in order to sort of even start the scheme, Manx Care have had to give an assurance that the recurrent funding is there in 3 years' time or 2 years' time when that non-recurrent has finished. In terms of primary care at scale, I think the other challenge is around, GPs are independent contractors, and so ultimately they could say, no, we just want to do what's in our contract. I've been out to meet the majority of GP practices over recent weeks around getting this alignment between the wellbeing hubs and the services out in the community, and making sure they are absolutely as joined up as possible with primary care services. And I think the North is the great example, where you've got one practice, Ramsay Group practice, who's actually running the wellbeing hub, and it's exactly as we would model. It needs to look probably slightly different in every geography, because one size fits all and you've got multiple practices. But equally, in order to transfer work out of the hospital, you will probably still need a service in the hospital. You have to still retain something in secondary care, but money has to shift out and be put into the communities through either enhanced service or different services. So that sort of double running whilst you make that transition has been a real challenge. And as I say, I think we spend probably only a modest amount on GP contractors, and it is very much for their discretion as to whether they really want to engage and deliver an enhanced range of services, even if there's the funding available. So I think we've got to be quite agile, and that's why having that relationship with the GP practices is really important, so we can actually try and build on the relationships, but also the strengths of what they're interested in doing, and how we then wrap around and supplement that with the wellbeing hubs, and what's possible in each area. So those discussions have been really helpful, and working through the primary care network too.
Thank you.
Can I just ask one question there before we move on to the next topic? And that just set me thinking when you mentioned Ballasalla, and obviously Manx Care had come in to take on that practice. So my question really is, and I know you're building up relationships, as you've just said, with all the GP practices, but are we working off the wrong model in the first place? In terms of primary care, in terms of GP practices, do we do the Ballasalla model more? And the same, I guess, with dentists?
Yes, and we explore this in the primary care strategy. And I don't want to steal your thunder, Oliver, but essentially we've developed, as part of the mandate, the salaried GP model. We would always want to make salaried GPs, attractive proposition, something for contractors to consider if they wish, and that's what we've gone out and had the discussions. Have they seen the salaried model? What's their opinion of it? We would want to co-produce it. We have, as a board, stayed clear of the sort of it's either this or it's this, because actually we have to respect GP contractors. It is about the relationship and working together, and I still think that's the right strategy. The partnership working where we can yield a lot of benefits. Manx Care has been very successful in recruiting 2 salaried GPs, and will continue to sort of supplement and provide that. I think Ballasalla has gone incredibly well for us. It's a lot of extra work, and it actually costs us slightly more, because we haven't got the economies of scale. And the primary care at scale definitely spoke about those economies of scale. You know, we don't, if you think about practice management and back office functions of primary care, you know, there are certain economies of scale if we were to shift that model. But I still think it's about respecting those relationships with contractors. I do think, and this is where we're in discussion with the DHSC about a different contractual framework, because I would suggest we don't necessarily have the level of contractual levers we would wish to have around our existing contracts. And I would suggest, well, we know that there's work ongoing to look at those, because we do need to have the assurances around delivery. And if I took the dental contract as an example, if our contractors under-deliver against the units of dental activity that they have been commissioned to deliver, we can't recover that until the following year.
Yeah.
So we've got an in-year deficit of delivery, and we don't actually... we aren't able to claw that money back until the following year. And that's not right in terms of the pressures we've got on dental provision, that we're not able to react and respond to under-delivery of contractors. I don't know that would happen in any other situation where you have a contractor who's under-delivering. And we need to understand why and work with those providers, but we definitely want a different contract in place to be able to exercise some of those levers if we need to.
Go on, you do that.
We can start.
Well, okay. Whether we've got the wellbeing partnership assessments, and do these have to be completed before a person can access services through the wellbeing hubs?
No, well, so there's a number of ways that people can access wellbeing partnerships. They can be referred by any healthcare practitioner. So whether that's a nurse in the hospital, whether that's a social worker, police officer. And people can just drop in. So in the wellbeing partnerships in the south and the west, there is a front desk there. So people can drop in, speak to one of the referral coordinators, speak to them about, they might be having, needing some advice around signposting, around care coordination, etc. Slightly more difficult in the north because we don't have the estate to enable that, but we do have drop-ins twice a week in the town hall, and we also have a presence around twice a week in the GP practice, so people can drop in and essentially refer themselves.
Thank you.
Okay. So just move on to social care now. So recruitment and retention of social workers has been a challenge historically. What is the position now?
If I start off, Teresa?
Yeah, of course.
So,
yes.
as I referenced at the start, we're making some progress in ensuring that some of our agency workers convert to permanent members of staff. So we're doing a lot of work inside teams to support colleagues to make that transition. I have to say it's not always easy. And as I'm sure you'll be aware, we support incoming social workers in various ways to make life as easy as possible for them when they come. But we are making some progress. It's, to use a phrase Teresa just used, it is quite intensive work for us to do that. And I'm keen for us to develop more capacity and capability in OHR to help us and support us in that space. A lot of the heavy lifting is at the moment done by our own management team. But the OHR support we've got is very good, but we just haven't quite got enough of it. We're also trying to do more in terms of understanding the market in the medium term, understand our competitors better. We do have groups of social workers who move from island to island, for example, and others obviously who come from the northwest of England, for example. So understanding more about that and understanding what attracts them, but also, probably not the right phrase, but selling hard the benefits of working on the island, which are absolutely real, but sometimes quite difficult for social workers and other key professionals to kind of see with their own eyes. So I've been involved in various what you would describe as innovative recruitment campaigns to try and drive that, and I'm very keen for us to implement similar models here. And then, of course, when they arrive and we support them into post, we need to make absolutely sure that our social workers and other key professionals are well supported to feel settled and happy and contained in their work. And so we're putting quite a bit of emphasis on training and development and supporting them to integrate within what can be an environment that feels quite new to them. You know, we do certain things differently to other systems and jurisdictions, and we have to strike quite a careful balance between supporting them to understand how we deliver practice differently on the island, but also we want them to bring the best of what they've learned elsewhere. So it's a careful balance that we want to strike, and we're working increasingly hard to try and do that. And we have had some success both in adults and children's services in recent months, in both recruitment and retention.
And how reliant are you on, I assume it's agency, you know, coming in for the week and then going back to the UK or wherever for the weekend?
So agency and bank, in some parts of my services, we're still reliant to a degree. The cost improvement programme has presented us with some opportunities, actually, to challenge ourselves harder about how we move away from that. There are occasions also when agency staff actually are the right solution. So I would say that, but often, in my experience, bringing staff in and enabling them to understand our culture and way of working and the island's benefits is the right way to go. So I would like those numbers to continue to come down, and we're working really hard to do that. And the cost improvement programme that we've run is really just a framework within which we want to deliver some longer term benefits. And my experience in different jurisdictions, if you can develop a strong, stable workforce that know the island, that know the communities, good things will flow from that in terms of supporting particularly older people in their own home for longer.
We've had some particular success when we sort of looked at the non-registered workforce, so expanding the assistant social worker role. They're able to carry, a caseload, they are supervised. But when we struggled to recruit registered professionals, we took the decision to convert 2 posts into 5 assistant social work posts and recruited those. And though they have been excellent, really value added to the team, and embedded in localities, so they understand the caseload and the population they're serving. But also then being able to train our own social workers, so re-establishing that training programme to train social workers here on the island has been really positive.
That was my next question, really. How much sort of input are you putting into that grow your own? I did see you were down at the skills exhibition at the village. Did that kind of be quite positive for you in that?
Yeah, I think, we try and take those opportunities. So I think definitely having a clear and concise training offer here on Ireland, working with the universities, and taking the opportunity, even just something like TT, when we had the opportunity to be on the radio every morning and talk about the professional services we deliver on the island and the different roles. We got a number of inquiries through that route, and I think you've just got to take all of those opportunities and try and max them out. But it is definitely about looking at where the non-registered workforce can really add value. And as well as assistant social workers, we've now got maternity support workers supporting midwives. An established role with key skills and standards and accreditation, a clear competency framework so they're kept safe. But these are the types of workforce opportunities that we have to keep looking at. So registered professionals having the opportunity to work at the top of their licence, and a real breadth of non-registered workforce which allows them to sort of upskill and keep that job satisfaction and that succession planning, and prepare them if they wish to go on and do their registered professional training. And those are the pathways we're looking to consolidate here on the island.
And some of the feedback I get from social care staff is understanding they can develop their practice far more quickly here than they can in other jurisdictions. They get to experience more, develop corners of their practice they would take years to develop. And we're very aware we want to support colleagues to do that, and that's not for everyone. We're also very clear about that, you know. I think over time we're becoming a bit more savvy about understanding the mindset that will work well on the island and flourish in you know, what can for some people feel like quite an unusual set of circumstances to come to.
And when you have a reliance on agency staff to any extent, you know, how is that managed with the turnover of key workers, or how's that managed with clients? Is that difficult?
It can be difficult, so we're conscious of that. And so if you take children's services, for example, I know Julie and the team do a lot of work to try and remain, to keep consistency of practice, particularly as you go up the threshold in terms of complexity. It's really important that you establish that. And almost wherever I look within my services, we're doing everything we can to try and achieve that consistency, but also be very open and transparent when that's almost impossible to achieve, and make that transition to a new professional as easy as possible. Referencing what Oliver said earlier about data, we're on an improvement journey in terms of supporting staff, but also parents and carers to be able to feel confident that the kind of data trail and the understanding of the casework is shared. But we're optimistic. We're doing a lot of work on the single care record, as you'll probably be aware. That for us is a really important long-term gain for us in being able to share consistent and up-to-date information with families, parents and carers if professionals do change, to make that transition a bit easier.
Okay. So I've got just a few questions about foster carers, actually. And can you tell us about the work that's underway to increase the number of foster carers?
I can take you to Starbucks if you like. So I'm really excited by this work. So we started way before I arrived, but we've been able to make some good progress in attracting new foster carers into our system, and a number of those are going through the relevant processes at the moment. I've personally met some of them both in Starbucks and elsewhere. And it's great credit to the team pulling every lever possible to encourage residents to get involved, and we've had some really positive feedback. We're going to have to keep turning the handle really hard. I mean, they are critical roles. Our narrative is really clear. They are some of the most important colleagues we work with right across the system, and we need to make sure they feel supported and again feel contained in what is a very, very challenging environment. We're not there yet, I don't think, and we've still got work to do, but certainly we're very aware that's very important to us. You know, every new contact we make, we cherish. And I have to say, you know, a word of thanks to colleagues who are in that space already doing the most outstanding job.
And where you are in balance between what you have and what you need?
So we're on track this year. There are a number of variables associated with that, as you'll probably know, in terms of bringing foster carers into the system effectively. But we're already planning for next year. So watch this space in terms of our work, which hopefully we'll move on a stage from what we've done this year. We've learned quite a bit from this year in terms of communication out and how much capacity we can and should spend in that space. So we'll learn from that and do more next year. But I'm optimistic. You know, we've made a good start and we've got traction. I think for a number of years before Teresa and the team started the programme of work, we'd struggled, I think. So cautiously optimistic, I think, is the way I would describe it.
Good. And the Mockingbird programme, is that still in, or?
So we're looking to continue that in the future. At the moment it's paused, but we're very, 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 very keen to continue that programme into the future. So and we're conscious, again, I've used this phrase a few times this week already, it's one of the elements that we would describe as being best in class. We'd want to be able to continue that.
Thank you. Okay. Mrs. Kinnish.
Thank you. Could you just give a very brief overview of what services are provided by adult social care, and from those services, what services have been withdrawn or ceased in the last 24 months?
Across adult social care?
Yeah.
So I'll try and describe it as simply as possible. We have quite a complex setup, which I'm currently working to simplify. We deliver services to residents with learning disabilities. We deliver what I would call as a pre-65 team, so residents who are coming up to 65 and earlier, 18 to 65, and then a post-65 team as well, so for older residents. We obviously have a residential care programme as well, and that's our residential estate, so that we capture that within our adult social care services as well. And we also have adult safeguarding services, so we have an adult safeguarding team with a principal social worker at the heart of that team. We also have a community support service that supports adults with what you would describe as lower levels of need, and we can support in the home effectively. And I think what I would say about that is that those teams are working increasingly effectively together. I think one of the things that I noticed when I came into role is that getting those teams to work across, they're all quite small, discrete teams, is really important, particularly in terms of transition, either in terms of age or in terms of complexity of need, something I'm very focused on. In terms of what we deliver, so in really simplistic terms, we deliver services in the community and we deliver services in the residential estate. It's a mixed economy. I suppose what I would describe how we deliver service at the moment is a combination of commissioner and provider. So some of our services are commissioned through 3 primary providers, and some of them we deliver directly ourselves. And that's something that I'm looking at the moment from a strategic point of view in terms of how we might get better value for money from that mixed economy of services at the moment. An example of that, we've just started a learning disability review with an external partner. We are in a position at the moment where we have an estate with a small number of residents in an estate, and we need to look at how we deliver services more effectively in the community for some of those residents, certainly coming through the system rather than those residents who are already in residential care. Both from an outcomes point of view and a value for money point of view, we certainly should be looking at that. And we've had feedback from parents and carers to that effect as well, and I've met with a significant number of parents and carers and talked to them about those kinds of issues as well. So that's something I'm looking to in the future in terms of both value for money and outcomes for residents. In that space as well, of course, is our day services that I'm sure you'll be familiar with, and spend a lot of time at Tall Trees. Again, we need to look critically at whether the outcomes delivered through those services are good value for money, but also right for those residents in terms of what we want to achieve long term. And Sean Morgan, one of our heads of services, done some excellent work this year on developing pathways for residents to move into education or into employment or different pathways into the community.
So you just touched there on a learning disability review. Is that intended therefore to be a broad spectrum review? Because I'm aware that in 2023 there was a review of day service provision, which included not just older adults but adults with learning disability. So that's obviously quite a narrow focus. Is this intended to be a much more broad spectrum review?
It is a bit broader than that. And the problem that I'm asking them to help us solve is that our services are really stretched in that area, as I'm sure you'll know. To give one kind of real example of that, as you'll know, we're moving from Radford Bay to Summer Hill View, and as a result, we've had a vacancy freeze for a while in that space, and so that's really stretched us. We've released that now, so I've made some decisions to make sure that we're better staffed in that area in the coming months. But underlying that, it remains an issue around effectively staffing that area with a number of small provisions. So bringing an external review into focus is really about looking critically at that as a series of issues for us, and how do we deliver those services more effectively. And I think staff are also telling us on the ground, my 4 service managers in that area are also telling us, it's time we moved quickly on this and looked at some other options for delivering these services more effectively. So acting on that, we're doing that now, and we're expecting the review to come back by the end of January next year. So we're working quite quickly on that. And I think the other thing to say, Mrs. Kinnish, is what we're not doing is preloading that review with a series of assumptions. What we're saying is we've got sector experts to come and help us. We've got some, if you like, professional assertions we might make about what we see, but help us understand what are our options here moving forward. We know there's not an enormous amount of money coming through to us to improve those services in terms of either staffing or the capital estate, and that's a key area I'll just briefly mention in a minute. So we need to think inevitably about how we deliver those services better and ensure that some of our most vulnerable and complex residents get a great service from us.
And that review will include engagement, presumably, with third sector and families of service users?
It'll certainly touch on the third sector. In fact, we were talking about that only last week in the service specification work with them. It probably will be quite a light touch in the first instance with parents and carers, but I would expect us to engage with parents and carers on the outcomes of the review as we go through. And I doubt it will be the last time we engage on these. I'm incredibly keen on co-production. If I'm perfectly frank, we needed to operate with pace. Coming into post, I felt it was one of our areas we needed to work on pretty quickly. But we'll do everything we can to communicate with parents and carers, and they're aware of the review.
So you talked there about engaging with parents and carers on the outcomes of the review. Do you not think there'd be more of a benefit to engaging them as part of the review?
There would, and co-production is something I'm trying to make sure we do every time we do these kinds of pieces of work. The issue for us here is really working at pace. So we will do everything we can to communicate with parents and carers as we go through the review. It won't be a kind of six-month planned event in the same way, because I'm keen for us to move quickly. But your point's extremely well made. I would much prefer to be in a position where we could, in a quite staged way, communicate with parents and carers up front of the review starting.
I think my concern there is working at pace. If we slow down the pace a little bit, are we more likely to get a better outcome through that engagement?
It is really important for me to say, I mean, the views of parents and carers, as indeed the views of residents who are receiving the service, are absolutely paramount to what we do next, and that won't change. And certainly you can judge the outputs that we propose that we deliver based on expectations that parents and carers are coming to us with. I think it's an important point that you've raised around co-production, and we'll do absolutely everything to ensure that they're involved in the review as it goes forward, but also the outputs of the review.
Thank you for that. And perhaps the messaging that I would like to make to anybody listening to this or watching is that perhaps those parents and carers, in order to not be overlooked, should engage with those third sector providers in the charity sector to perhaps get their voices heard. Yeah,
so I probably wasn't clear. Certainly the third sector providers are part of the review, and I had the conversation with the provider last week, and they're including them in the review. And we have very good relationships with those providers as well, so I'm expecting that to flow through the review. And certainly quite rightly pointing to that as a key area for us. Thank you.
Just moving on, the target for older people, community social work and adult generic teams is set to complete 80% of wellbeing partnership assessments in 4 weeks. The achievement of that target since April 24 has ranged between 0% and 54% within 4 weeks. Do you know why this is?
Yes, I do. So our current October data is 33%, which is not acceptable, and that's the cumulative data on our assessment timeliness. Speaking to our new assistant director that we recruited in June or July this year, it's really interesting. The initial expectation that we would be able to fix this relatively quickly has not proven to be the case. This is really about culture and ways of working. So we've already put a framework in place and an action plan to address it. It's taking a bit longer than we would want and expect. And in simplistic terms, without repeating myself, it is about ways of working. It's not an acceptable position. I wouldn't accept it moving forward, and I'm expecting it to improve. Certainly, I've had a commitment from the service lead that'll improve markedly by the end of the financial year, which is what we're aiming for at the moment.
Thank you. And just moving on to the target that's been set under those assessments for learning disability social work teams. It's stated as 6 weeks, and those are 4 weeks, and then suddenly there's no threshold target at all for those. I just wonder if that's an oversight in the document, or whether there is no target for that area.
My understanding is it did sit at 6 weeks, and I've made the challenge to ask us to move to 4 weeks. I think that's what you're probably seeing in the documentation, but I'm very happy to confirm that. Certainly my expectation is that assessment should take no longer than 4 weeks.
Thank you.
Sorry, we are seeing that in the documentation, that it's 6 weeks for that one and it's 4 weeks for the others.
Yeah.
But whereas the others have a target of completing 80% within the 4 weeks. There's no target at all
Right.
for the learning disability social work team.
Yeah.
That's all. So perhaps if you could take that and look at it. It's QC 104.
Thank
if
you.
want to go and have a
Absolutely. And just for clarity, these are some of our most complex and residents that require our help and support the most. So the quicker we get those assessments completed effectively, the better. I'm conscious if one of my practitioners was sat next to me and they'd be saying, enable us to understand that complexity and ensure that we get, for example, psychologists involved in this, as I'm sure you know. But it's really important that we've got that as a marker of a system working well for residents.
Thank you. We've touched a bit on learning disability already, but I just wondered if you could just explain generally what support is available for adults with learning disabilities.
Yeah, so we have a community service, we have a residential service, and coming into role new, my desire and expectation is that we strengthen the community support. We have a limited amount of money to spend, as I'm sure you'll know, and as we were talking about earlier, some of our placements are extremely expensive, and so it's a sensitive and difficult piece of work to be able to use that capacity differently and use that money differently. But that's certainly the aspiration. We do certainly what we can, as I was describing with the day services, to support residents into employment, education, training and work. But I'd want us to do more of that. I think we have a number of services that you might, I think Teresa described it earlier as traditional services, and I would describe day services as traditional. They're highly prized by residents and parents and carers who access them. But having said that, my view is that we should be aiming to achieve a system that supports more community activity, more opportunity for those residents where it's wanted and needed. And certainly that's the feedback I've had from the parents and carers I've spoken to so far broadly. So that's the aspiration for what we'd want to achieve longer term. And I think we're at the beginning of that journey is the way I would describe that.
Can I just ask, in terms of the mandate with learning disability, there seemed to be an outstanding action of pharmacy services which was yet to be established, and social work service for individuals with learning disability yet to be developed. Are you aware of where these are up to?
On the pharmacy side, Oliver, is that one you're aware of? Just bear with me 2 seconds.
Yeah, I think it's related to medication reviews for learning disability service users, and that's something that we haven't been able to implement yet, just because of the capacity of the community pharmacy service. So that the pharmacists that we employ within Manx Care, but that are based out in the community. But that is an aspiration. Pharmacists are particularly difficult to recruit at the moment, both in a community setting and also in the hospital setting, and that's just one of the things that we just haven't been able to cover.
And on the social work side, our social workers are providing strong support to our learning disability team. That's something that I've introduced since I've been in post, and that's starting to work really well.
Thank you. For an individual with learning disabilities, what is available for them when they can no longer live in the family home?
So obviously residential care is one of the options for individuals with learning disability. We provide a range of what you might call extra care services as well, but they're nowhere near enough for the island at the moment. And referencing my earlier comments, I'd like us to be able to invest our money in a different way. If you looked at they're called something a bit fancier than a pie chart, but if you looked at a pie chart of how we spend our money in that space, what I would judge as too much of it is spent in residential care. Obviously turning that around is going to take a little bit of time, but certainly we're aware of it. We're putting plans in place to try and address that, and the learning disability review I mentioned earlier is a part of that. Also has to be dealt with incredibly sensitively, because both residents who access those services, but also the parents and carers who support them, it's a critical part of obviously them leading full lives, and we're very conscious that has to be dealt with very carefully, so we won't be kind of jumping into anything in that space. And I think our staff group in the residential estate do a really good job given the capacity that we've got in the system, which is incredibly stretched. And if any one of my managers was sat next to me, they'd be nodding furiously at this point. And certainly since I've been in post, I've done everything I can to enable them to have the support they need to carry on doing a good job. But that remains definitely a stress for us in the system.
That's in terms of staffing pressures, is it?
In terms of staffing pressures, yeah. Of course, it's a highly regulated system, and our interface with R&I is it's increasingly strong, but still a pressure area for us. Quite rightly, we use regulation as a means to improve practice and quality and safety, but it remains a stress for us in the system, I think, and so that's why we're looking at how we deliver those services slightly differently.
So according to the government website, there's currently 83 adults in full-time supported accommodation. I'm not sure if that's up-to-date data, but is there a current waiting list for people who need full-time supported accommodation?
I believe there is a waiting list, yeah, and we're doing our best to reduce that. I come back to what I said earlier about capital and about the estate. I'm in lots of detailed conversations with the head of learning disability at the moment about individual cases where, for example, the resident will be better served by a different type of setting, but we are incredibly limited in terms of how we can deliver that. We just don't have enough capacity to do that work. So we're one of the reasons, again, I'll come back to the review, the reason we're doing the review is because that's not a situation I want us to continue to be in. We need to develop different ways of delivering those services so that we can provide good quality support to residents with learning disabilities without being in the situation where we're struggling to provide the service that is required and needed. So yes, there is a waiting list.
Thank you.
Could I just ask, is there a pause on getting adults into sort of full-time supported accommodation at the moment?
I don't quite know what you mean by pause, sorry.
Just some things I've had from constituents lately that they've got children waiting to go in, are in the process, but it has been paused for now.
We've certainly had issues in terms of the amount of capacity we've got in respite, without question.
No, this is actually to go into supported living.
Not that I'm aware of.
Okay.
I think one of the considerations and it's a really important consideration that staff always raise with us, and I was at a home only a couple of weeks ago, is the mix of the individuals in the home is so incredibly important to get right, and in some cases we clearly have a 4-bedroom property where we only have 2 residents because of the individual needs of those residents and the appropriateness of adding 2 extra people into that space. And I think this is where Tim's so correct in terms of the agility and flexibility of the accommodation we've got often doesn't lend itself to. So if we were able to create sort of an extra care campus with flexibility where people could move through the transitions of their life, what suits somebody in their 20s and 30s is definitely not the sort of facility they would need in their 60s and 70s. And some of our properties are on 3 floors with lots of stairs, and don't necessarily support people to transition when actually this is their home, and it's their home for an awful long period of time. So a sort of a campus, extra care type of campus model would be the ideal vision to allow that transition where all that support exists and they can live close to a normal life with as much independence as they possibly can. And that's the ultimate goal that we would want to try and achieve. And
taking Mrs. Kennedy's comments on board, we need to take parents and carers with us on that journey, without question. Lives can be really tricky and difficult for parents and carers in that space, and sometimes a residential solution can feel and be the right solution for individual residents, but so that move to an extra care, more flexible model will take time to achieve, and I'm incredibly keen to take residents with us on that journey. It's certainly not a kind of slot in a new model and hope for the best. We're completely the opposite way around.
Okay.
Thank you. Has access to day services for those living with learning disabilities in residential homes been withdrawn?
Not that I'm aware of, no. We are looking at how we can remodel day services to get best value for money from them, but we're certainly not withdrawing them, no.
So it was my understanding that some social activities within those residential facilities had been reduced or withdrawn, and that that provision was no longer being made available.
So I'm not entirely sure what you're referring to, but certainly in the Learning Disability Review, one of the reasons we're running that review is because we're aware that we can't always deliver everything we want for residents in a particular setting, referencing Teresa's earlier comments about the restrictions in the settings, the ability to be able to fully support a number of different residents with different needs in the same space. So that's one of the reasons we're doing the review, is to try and develop new ways of working to help us with that situation. I think, you know, broadening it out from my point of view, whichever jurisdiction we're in, and our jurisdiction is no different, parents and carers' expectations outstrip what we can deliver without question. And so what we need to develop is a model that can best fit the financial envelope we've got available. And as you were saying earlier, working in tandem with parents and carers and with the residents themselves to achieve that is the right way to go. It's definitely true to say that, you know, we can't hand on heart say that every provision is exactly as we want it to be at the moment, because it isn't.
Thank you. I very much look forward to the outcome of that review.
Thank you. Look forward to bringing it forward.
Just got a couple of quick ones on... there's an integrated women, children and families care group. Can you tell me what services are provided by them?
So there's the traditional hospital services, which is obstetrics and gynecology, midwifery, so maternity, delivering babies, neonatal unit, and paediatrics. So paediatrics being paediatric outpatients, so that's seeing children who are referred to the service by GPs for various things, whether that's asthma, allergy, orthopaedic problems. We have a visiting service from Alder Hay, constipation, dermatology, and yeah, so it's essentially the secondary service. And then from a community point of view, we also operate the Children's Community Service, which is a small team of about 5 nurses that provide care to particularly complex children in the community. They also deliver chemotherapy to children in the home, and we also deliver the health visiting and school nursing service out of that care group as well.
Thank you. I just want to go back now to children and families social work. The number of re-referrals in children and families social work was 53.1% in July, and we'd just really like to know to what extent is this impacting the CAMS waiting list?
That's a very good question. So I think first of all, in terms of re-referrals, we'd obviously want that number to come down, and the work we've done around the multi-agency safeguarding hub and the work we're intending to do around moving towards more of an early help model should help us bring that number down. It's too high at the moment. Obviously sometimes re-referrals are required and necessary, but you know, in a well-functioning system you'd expect it to be lower than that. There is a connection point with the CAMS waiting list, but certainly I think, as mentioned in my introduction, the work we're doing to bring the waiting list down with committed clinical capacity, and the work we're doing also on the Thrive model to develop CBT services, therapeutic services to support children and young people rather than moving them straight into a treatment pathway, should help us enormously in that space. And you know, there's a huge commitment from staff to deliver that over the next 12 to 18 months. There is a connection point between them two, but I think those two things running concurrently are absolutely at the top of our agenda moving forward.
Okay.
We're right up against the clock, unfortunately, so we may well, in some areas, particularly mental health, which she wants to focus on, it's an area I'm particularly interested in, put some of the questions in writing, if we may, to you. But just a couple, if I can just focus on a couple. The percentage of re-referrals into mental health services after 6 months, and this is taken from the chart, has been steadily increasing in the last 12 months. Can you say why this is and what steps are being taken to address it?
So the team is absolutely focused on bringing down the numbers of re-referrals, and the overall strategy is to invest in early intervention services. I think certainly if we started from an earlier point in time in the assessment as to the percentage of re-referrals, it would probably paint a slightly different picture. But you're absolutely right, we want to bring that down. Certainly if you talk to the team, you're very welcome to come and talk to services, as I'm sure you may well do. You're very, very welcome. You'll see an absolute commitment to driving that early intervention model. And that's taken a lot of hard work, I think, to get to that point. Another area perhaps where we've had quite a traditional mode of practice in place that we're trying to shift relatively quickly. Re-referrals when they're necessary will remain necessary, and we're very conscious of that from a clinical point of view, but very keen to bring that down.
And how and when will the implementation of the Thrive model affect waiting lists at CAMHS?
So the programme, I've got a very large green file in front of me. I was just looking at it before we came in. So I think we've got about 800 children on the waiting list at the moment. I think in previous reports it was quoted as around 1,300, so we've already made a bit of an impact on that. The programme of work is the next 12 months, with the focus being those 6 clinicians, and that programme of work is very tightly programme managed, and we're looking to drive that over the next 12 months to bring that down to very acceptable levels. Whether the waiting list ever gets to 0 is a completely separate question, which I'm very happy to come back and talk to you about. But certainly we're looking to make big inroads into that waiting list over the next 12 months, and spending quite a bit of time over with the head of service and his teams there. Absolute focus on delivering that.
I think, and again, one of the positives that's come out of that broader CAMHS investment has been the ability to put in a single point of access, and because actually what we had was the only service available largely was CAMHS, and there was a lot of individuals in the CAMHS service. I mean, the quotes were up to 60% of people, young people who were in the CAMHS service really could have been dealt with by a different type of service. So it's part of the plan to make sure we've got the workers within the schools, where sort of we can capture people early and do some of that supportive work around building resilience and supporting young people in the school setting, but also working with our local charities, and we've just recently awarded the contract to enable us to have that single point of access and that early intervention offer in contract with a local provider. So we can start to do that shift whereby you are only in the CAMHS service if you genuinely need to be seen by the CAMHS service. And I think that is the shift. That's the exciting shift, that we can start to see the Thrive model really taking shape, and some very clear roles, responsibilities and outcomes sitting in those 4 quadrants around what happens, before people really need the help, sort of that really preventative model which sort of sits in schools and communities, the sort of early help offer which sits with our voluntary and community sector partner who have excellent outcomes, the CAMHS which has a real clear role and broadens out into systemic family therapy, for example, because it's not just about treating the young people, it's often about treating the family, and then that more specialist area where we're really clear about what the sort of CAMHS Plus model looks like and how we support people to remain on island if possible. And I think this is one of the successes we've got of the service, is that we haven't had to send many people off island. We will never be able to have a CAMHS inpatient service on island. The standards are just so high for what that looks like, and the expectations are. But actually a CAMHS Plus model would allow us to be able to offer that support for those most needed and who are probably on the edge of having an inpatient stay. And obviously that's where the pathway into the UK has to happen for those that genuinely need it.
I'm just going to move now to the multi-agency support team. So I think that's safeguarding team actually. The pilot for the MASH team was undertaken in the latter half of 2023. Has this now become an established service?
So really positive feedback report first of all, which is kind of it's probably not the right phrase, done the round. So we've shared that report widely, and there's some positive outputs and outcomes from it. We are at the moment struggling to staff permanently the MASH. It's, as I was describing at board earlier this week, it's best in class. It's absolutely the right thing to be doing, and I'd be keen to develop further synergies with our front door services elsewhere across the island from a children and adults point of view. Very, very keen to drive it, and we're in conversation with colleagues in different partnerships to try and achieve that. But at the moment we are short of a permanent staffing complement for funding reasons. But we're not going to give up on that, because it's the right thing to do. It's the right thing to do for the island. And as I say, the results have been really positive in terms of information sharing and bringing staff together from, as you all know, police and health and social care and probation and elsewhere to affect positive change for in an early intervention space. So very keen to do that. We've still got some challenges at the moment around staffing that permanently.
Yeah, we look forward if you could share those reports
very happy
in relation to that. Can I just very quickly, just for my own understanding, when you're saying you're struggling to staff those permanently, as I understood it, the MASH team was made up, as you've just explained, of lots of different representatives from different areas. So where is the struggling to staff permanently area?
So we've had to move staff into it from our establishment.
So specifically social care staff,
and
right.
so what we'd like to do is to fund those staff permanently, so that we're not kind of borrowing from elsewhere in the service in order to achieve it. That's effectively what I'm saying.
Thank you. Just want to move to dental services, and obviously there's been a headline this last week or so around the increase. Can you tell us what work's underway in relation to dental services, and if this will reduce waiting lists, particularly for young people?
Yep. So we've got 5,800 people on the waiting list at the moment. That has grown over the last 2 or 3 years. The number of people who have got an NHS dentist hasn't really changed for the last 10 years. That is around 43,000 people on the island are registered with an NHS dentist. That fluctuates as people drop off being on a list, so if somebody doesn't access dental services within a certain period of time, they drop off, and then when that happens, then we add people from the waiting list. But the number of people registering or going onto the waiting list is outstripping the number of people that are coming off. Since we took over Hillside Dental practice following Portman's giving up the contract, we've used the funding that was within that contract to staff up to 2 dentists and a full support team, dental nurses, admin assistants, etc. And at the moment, the priority within that practice is to work through the backlog of patients that Portman had, because they were carrying vacancies within that practice. They got behind on their checkups. So even though the people that were registered at Hillside were registered with a NHS dentist, there was a significant backlog of them having their regular checkups. So what we've been concentrating on within there is to make sure that they are all they've caught up with their checkups and the necessary treatment. They're around 50% of the way there with the plan that by the 31st of March they will have caught up with those. Once they've caught up, it means that now there's going to be capacity within Hillside to take on more patients.
Just a bit mindful of time, Oliver, but just in terms of where if capacity arises or where people drop off the list, will there be a particular focus on trying to address young people's needs?
I answered a Timor question this week around dental, because as we're recruiting an additional dentist into Hillside and converting some space that is currently storage into another dental surgery. Once that conversion has happened, and if we are successful in the recruitment, we'll actually be able to absorb the entire waiting list into Hillside. So the 5,800 people will be able to absorb, so that will clear the waiting list, which is great. It doesn't necessarily, because there is no eligibility to join the waiting list, there is the possibility that, the number of NHS patients will go up from 43,000 to 49,000, but that still leaves another 35,000 people on the island who are not with an NHS dentist, and those people could decide to actually, I want an NHS dentist because it's significantly cheaper. So we do need to be conscious around not ending up in the same situation in a few years. So we are in early dialogue with the DHSC around whether the introduction of eligibility to join the NHS to get an NHS dentist should be introduced. I think our priority, I think the board's priority, is to make sure that people who can't afford dental treatment privately get the ability to access NHS funded dental treatment.
I think it's a very clear example of a strategic policy decision which needs to be above Manx Care, because ultimately, if we, for example, I'm not saying we should, but if we applied the criteria that the England use, we would have 18,000 people on the island eligible for free dental care. And that's quite a significant change from the numbers we have. It may be a strategic priority of the island to make sure everybody has access to an NHS dentist and gets free dental care, but ultimately there's a policy decision and a cost about that. But we absolutely recognise how important dental care and primary care is, I think, to the health of the population. So we hear that loud and clear through the feedback of the importance of it. But ultimately, it will be a policy decision and an area where we collectively agree this is a funding priority and something we would want to invest in terms of capacity to be able to deliver that aspiration for the island.
Could I just ask, is there any formal structure and policy around used for the prioritisation of dental patients?
We would take children off first. Yeah.
Okay, that's fine.
And we tend to, if there's families registered, we will take them as a family.
That's fine. Okay.
Thank you.
Okay.
I had another question, but we'll convert that to written if that's all right with you.
Mm-hmm.
We have got a few more, which I think we should convert to written because we've gone way over time. So just before we draw the session to a close, is there anything else you'd like to share with the committee?
Where do we start?
Briefly.
No, well, what I would say is Manx Care has, since its inception, always focused around its 4 priorities. We absolutely have to deliver safe, compliant, good quality care, and I hope the evidence that we have given today demonstrates our focus around making sure the practice that we have within Manx Care is best in practice, comparable to the UK, and achieves great outcomes for the population. We also want Manx Care to be a great place to work, so the cultural improvement work, which we probably haven't touched upon today, is equally important to make sure we are able to recruit and retain staff, and we have an environment which supports staff to be open and transparent and continuously improve. The finances have been a challenge, and we absolutely acknowledge that. I think it comes back to my original point. I don't think there was anybody who signed up for the Sir Jonathan Michaels report in 2019, even despite a global pandemic, no one anticipated this to be a short journey. This was a 5 to 10 year journey of improvement which needed to be built upon year and year from firm foundations to provide a sustainable model of healthcare for the island, and that is what Manx Care committed to. I think we are 3 years in, but we have just reached a period of service sustainability in terms of quality and compliance and recruitment, and what I would call the basic foundations and building blocks from which we really can start that next phase of very proactive transformation and delivering those ambitions for the island. But I would suggest we've taken 3 years to really achieve that level of sustainability. And it has been through a huge amount of incredible hard work and dedication of our staff to move with us to what I would suggest in some areas deliver 10 years of transformation into. And I can see the evidence of that. And it's a constant source of disappointment that can't always be more broadly understood outside of Manx Care. But when you have external peer reviews who say how excellent we are, and it was very different 2 years ago, and this is around the most critical pathways, major trauma and critical care, and our peer review colleagues who are experts in that field say what Manx Care deliver is excellent, then I think we're proud of what we have achieved, and I think we can replicate that across a number of areas where we know we have improved outcomes for individuals.
Thank you. Well, all that remains is to thank you all very much for your time today, and the committee will now sit in private.
Thank you.